Hello everyone, I'm called Dr. Rahma Shihama. I'm a gender practitioner. Today we're going to be talking about post-exposure prophylaxis, yes, which is called as PEP. I think most of you have heard about it before. Basically, what is it? PEP is basically the use of ARV drugs for a short course of time to prevent the likelihood of acquiring HIV after a potential exposure. That doesn't mean that we shouldn't observe the necessary precautions when dealing with HIV patients. So it's important that we observe the necessary infection control strategies as much as PEP is available. Also, when seeking PEP, we should use appropriate channels to help in the better delivery of the PEP services. So, which type of exposures are we talking about? Basically, we can divide it into two classes. One is the occupational exposure, and the second is a non-occupational exposure. Occupational exposure is whereby we're talking about the exposure that happens in our profession because we're dealing with many HIV positive clients. Let's say a needle stick injury, a finger prick, maybe while cannulating a patient, maybe during surgery, you got a nick in your skin. So all that is exposure. That comes because of our profession, okay? The second thing could be like maybe a splash of body fluids of the patient that attacks you, maybe to your skin or to your mucous membrane. Maybe it splashes in your eye, something like that, maybe during a procedure, during surgery. So all that comes under occupational exposure, which most of us in the health field can face. There is a chance. The second is non-occupational exposure. When we're talking about this, we are talking about like the non-medical personnel. Let's say someone is involved in a road traffic accident. They're exposed and maybe somehow they come in contact with something, maybe blood or something of an HIV patient. Second, let's say sexual assault. So this person may not be a doctor, they may not be a nurse, but it's because we don't know the other person's status, they are at risk. So this is what we call as non-occupational exposure. Then the other thing is maybe someone has a sexual intercourse with a person who is HIV positive, yet the person is HIV negative. Or maybe they have intercourse with a person whose HIV status is unknown. So that's also a potential exposure. Okay, so what are the steps involved in providing PEP? So there are 5 steps in providing PEP. The first step being clinical assessment and providing first aid. As a healthcare professional, if a patient or anyone comes to you, or maybe your fellow colleagues come to you, you should do a rapid assessment. Is this person really in need of PEP? Were they exposed to a potential HIV environment? So that is what we call as clinical assessment and providing first aid. So for example, if someone has maybe someone got a needle stick injury, what are you going to do? So the first thing you do is look at the site, clean it with water and soap. Simple. Don't use irritating substances like iodine. I know iodine is used in surgery, but that doesn't mean you go around using it every time. So basically, make sure that you use just water and soap. And don't rub the site, don't squeeze the site, just simple cleaning is required. Okay, the second step is eligibility assessment. Here we're looking at if the person who's seeking PEP is actually eligible. Like, let's say, when you're seeking PEP, it should be as soon as possible. Okay, there's no use of coming after a week. Okay, so that person really wouldn't need PEP anymore. The ideal would be to seek it within 2 hours, but not more than 72 hours. So you have a deadline of 72 hours. So within that period, you can seek PEP. So when they come to you, you should make sure when was the exposure. You're supposed to know that period. Yeah. Then also, is this person, when they seek PEP, are they HIV positive or negative? So it's very important we perform a HIV test for the person who's seeking it to make sure they're actually HIV negative. Because if they're positive, there's no need to give them PEP. Secondly, the source should actually be HIV positive or the status is not known. Like, let's say you as a doctor get a finger prick. The patient, the person who you exposed to, is he actually HIV positive? Because if he is negative, there's no need for you to get PEP. So he should actually be positive, or you're not sure of their status. Many times it happens, maybe they came as OPD, it happened, maybe the patient went away fast, so you are not able to follow up. So their status is not known. So you're not going to wait to follow them up, you're just going to start your PEP. Another scenario would be if the source is at high risk of HIV. Maybe they have not tested, maybe we have not tested them, but we suspect this patient, high chance, there is a chance he could be HIV positive. Like you see, maybe they have TB, they have many other infections that usually target immunocompromised patients, but his status is not yet known, and maybe there's some kind of delay. Sometimes when we're in resource limited settings, sometimes there's a delay in testing. So if you see some individual is at high risk of HIV, even if you don't know their status, you can actually go for PEP. When are the times someone is not actually eligible for PEP? Let's say the source is actually HIV negative, that person, there's no need to get PEP. Or you, the person who is exposed, is HIV positive, there's no need of PEP. Or let's say let's say if you came in contact with body fluids like maybe saliva, that's not blood stain, maybe in case of kissing, or maybe tears, sweat, those things are very low risk transmission. So these kind of scenarios, you're not going to give the individual PEP. Okay, the next step is counseling and support. Here we are looking at things like what are you going to tell the patient who is seeking PEP? We're going to tell them the risk of still acquiring HIV because of the potential exposure. As much as they're going to be on PEP, there is a chance. Secondly, the side effects of ARVs. As much as ARVs are there, they really have their own side effects, and it can treat each individual differently. Some are organotoxic, some are cardiotoxic, some are renotoxic. Yes, so those side effects should actually be told to the person who's going to take PEP. Not only that, it has other side effects like hallucinations, because I've had colleagues who have taken PEP and actually stopped it because of the side effect it gives, like hallucinations and that. Some people, it really treats them badly. So all this should be told to them. They should get a proper counseling before they actually start it, because otherwise they're just going to stop midway. And there are some who have actually stopped, people I know. So it is very important you explain to them the side effects, and also explain to them the need to adhere to it, because it's given for 28 days period, and make sure that they take it for this complete 28 days. Otherwise, it won't do any good. So the adherence is very important. Another scenario whereby if patient is maybe, or the person seeking PEP is actually sexually assaulted, what are you going to do? Are you going to just give them PEP and stop there? No, you're supposed to link them to other services, right? Maybe the police. Of course, you give the patient that right. You explain to them, yeah, because some people may not actually want to go through the other steps. So you tell them and try to link them with social support or things like that, if they're comfortable, of course. So the last step is the prescription. This is whereby we are actually talking about the ARVs we're going to be giving the patient. Some of the drugs we use, I'm just going to go through it briefly. Then I'm going to go through the regimens we use. So we have tenofovir, which is TDF, 3TC, lamivudine, DTG, dolutegravir, TAF, tenofovir, alfenamide, FTC, emtricitabine, ATVR, atazanavir, ritonavir, then efavirenz, EFV, lopinavir, ritonavir, then ABC, which is abacavir. If you want, you can pause the video and just go through the drugs briefly along with the acronyms, because mostly we use acronyms. We don't be talking about drugs usually. We just say TDF, 3TC. So you can just have a look at it by pausing the slide, and then we'll continue. And the recommended regimens include, the first line usually is TDF, 3TC, DTG. That's one combination. Or TAF plus FTC plus DTG. So what you have to know, these drugs usually come in one tin, and it's just one drug, one pill a day. Yeah, so they're all combined in one pill. The first alternative being tenofovir, lamivudine, atazanavir, ritonavir. That is one regimen. Or you can use TAF, FTC plus atazanavir, ritonavir. Second alternative being TDF, 3TC, EFV, or TAF, FTC, EFV. So these are the recommended regimens we have for adults. Now let's talk about the children who weigh less than 30 kilos. Yeah, whereby the first alternative being abacavir, lamivudine, dolutegravir. So this is basically all the regimens, and we're almost getting done. Now, like I said, PEP is usually taken for 28 days. Any chance it shouldn't be delayed starting, maybe because of delayed testing and all. Sometimes it happens, testing is delayed, but that shouldn't prevent you from starting the drugs. And like we said in the beginning, we should always approach the appropriate channels. Yeah, because these channels actually record these things in the PEP register. So that shouldn't be forgotten. Don't just go anywhere, go to properly affiliated places. Lastly, we come to the fifth step, which is follow up. You're going to review your client after 1 week for seeing adherence. Are they really taking the drug? They'll come and tell you, you know what, I took this drug, it's taking me badly, I left it. Or some people will say, yes, I'm taking it. So all that is important, because that is also a point of counseling. If they are not taking it, you're going to counsel them. So that 1 week is important to check their adherence, and also ask them how is the drug treating them, and give them the necessary advice or strength to still keep taking it. Then secondly, they should come after a month for testing, to do the HIV test, then come after 3 months, then lastly they'll come at 6 months to do the test to make sure the HIV negative. Okay, after all this, by any chance, if someone turns out to be positive, they just link them to a proper HIV clinic. Most likely the clinic which is giving PEP also has the routine HIV clinics. Yeah, they should be counseled and they should be started on the ARVs just like any other HIV positive patient. Yes, thank you so much. I hope this video is very helpful. Yeah.
If you enjoyed this video, please give it a thumbs up and share it with your friends. You can also subscribe to our channel for more great content. And don't forget to follow us on Instagram, Twitter, Facebook and TikTok.